Genetic testing has undergone a transformation that changes how we approach NICU diagnostics. We've moved from examining individual genes to analyzing entire libraries of genetic information simultaneously. Traditional approaches required specific clinical hypotheses before testing. Karyotype analysis detected large chromosomal abnormalities like trisomies. Fluorescence in situ hybridization targeted specific regions when you suspected microdeletion syndromes. Targeted gene sequencing examined individual genes for suspected disorders like cystic fibrosis. This created a diagnostic challenge. You needed to know what you were looking for before you could test for it, often leading to months of sequential testing while critically ill infants remained undiagnosed. Modern genetic testing casts a wider diagnostic net from the beginning. Chromosomal microarray serves as first-line testing for infants with multiple congenital anomalies, detecting submicroscopic deletions and duplications that karyotype analysis misses. This identifies clinically significant abnormalities in 15 to 20% of infants with multiple anomalies and normal karyotypes. Whole exome sequencing examines all protein-coding regions simultaneously, identifying genetic diagnoses in complex cases where traditional approaches failed. Gene panels focus this approach by examining multiple genes associated with specific phenotypes like cardiomyopathy or seizure disorders. The cost reduction has been dramatic. Genetic testing costs have plummeted, making comprehensive genetic evaluation accessible for most patients, rather than being reserved for the most complex cases. Karyotype analysis represents the foundation of genetic testing. This traditional approach examines chromosomes under a microscope after arranging them in organized pairs, requiring actively dividing cells, which explains why samples often need several days of culture before results become available. The process creates a visual map of all 23 chromosome pairs, detecting numerical and structural abnormalities. Numerical abnormalities are straightforward. Trisomies, like Down syndrome, show an extra chromosome 21, while monosomies, like Turner syndrome, show a missing sex chromosome. Large structural abnormalities become visible when significant chromosome pieces are missing, duplicated, or rearranged. However, the key limitation is resolution, approximately 5 to 10 megabases. You can detect major changes but miss smaller deletions or duplications that cause serious genetic syndromes. Balanced translocations present unique findings where chromosome pieces swap positions without losing genetic material. While these may not affect the carrier, they create risks for offspring who might inherit unbalanced combinations. This resolution limitation creates the most significant clinical constraint. Small deletions or duplications remain invisible to karyotype analysis, explaining why normal karyotypes don't rule out genetic disorders. Order karyotype analysis when clinical features suggest chromosomal abnormalities or when multiple congenital anomalies create suspicion for large-scale genetic disruption. However, understand that normal results may reflect the test's limited resolution rather than absence of genetic abnormalities. Karyotype notation follows a standardized format worldwide. The notation uses a three-part structure: total chromosome number, sex chromosome composition, then any abnormalities detected. A normal male karyotype reads 46, XY. The number 46 indicates total chromosome count, and XY specifies male sex chromosomes. No additional notation means no abnormalities detected. When abnormalities occur, the notation expands logically. Female trisomy 21 reads 47, XX plus 21. The number 47 signals an extra chromosome, XX indicates female, and plus 21 specifies which chromosome appears in triplicate. Turner syndrome shows how missing chromosomes appear. 45X indicates only 45 total chromosome, with a single X chromosome and no second sex chromosome. Complex abnormalities require additional descriptors. A male with 22q11.2 deletion reads 46 XY del 22 q11.2. The total remains normal of 46 chromosomes, but the deletion notation specifies exactly which region is missing. This particular deletion causes DiGeorge syndrome. Fluorescence in situ hybridization represents a significant advancement beyond traditional karyotype analysis. FISH technology uses fluorescent DNA probes that bind specifically to complementary DNA sequences on chromosomes. When viewed under special microscopy, fluorescent signals reveal whether target sequences are present in normal numbers or if deletions or duplications exist. The resolution advantage is immediate compared to standard karyotype. While karyotype analysis detects abnormalities measuring 5 to 10 megabases or larger, FISH identifies much smaller deletions and duplications invisible to traditional cytogenetics. Clinical applications center on detecting specific microdeletion and microduplication syndromes. The 22q11.2 deletion causes DiGeorge syndrome with cardiac defects, immune deficiency, characteristic facial features, and developmental delays. Williams syndrome results from 7q11.23 deletions, creating distinct phenotype, with cardiovascular abnormalities and unique cognitive patterns. FISH also provides rapid aneuploidy confirmation for trisomies 13, 18, or 21 when you need quick results without waiting for full karyotype analysis. The most important clinical pearl involves cardiac defects. All infants with conotruncal heart defects should receive 22q11.2 FISH testing because this deletion occurs in approximately 15% of cases. Conotruncal defects include tetralogy of Fallot, truncus arteriosus, and interrupted aortic arch. Early recognition of DiGeorge syndrome influences both cardiac surgical planning and immune system management, making this genetic diagnosis clinically actionable. Chromosomal microarray represents the next evolutionary step in genetic testing. While karyotype analysis detects abnormalities larger than 5 to 10 megabases, chromosomal microarray pushes resolution down to less than 1 megabase, dramatically expanding the range of detectable genetic abnormalities. This enhanced resolution makes microarray the first-line test for multiple congenital anomalies. When you encounter an infant with multiple unexplained birth defects, chromosomal microarray should be your initial genetic test, maximizing your chance of finding a genetic explanation while minimizing time to diagnosis. Microarray uniquely identifies copy number variants, duplications or deletions of genetic material that may or may not cause clinical problems depending on which genes are affected and the individual's genetic background. However, this enhanced sensitivity creates challenges. You'll sometimes encounter variants of uncertain significance, where clinical relevance remains unclear. This requires careful genetic counseling to help families understand that not every genetic finding explains their child's presentation. The most important limitation involves balanced translocations, which remain invisible to microarray analysis. Normal microarray results don't completely rule out all genetic abnormalities. The clinical impact is significant. Microarray analysis provides 5 to 10% higher diagnostic yield compared to karyotype alone, meaning more families receive definitive genetic diagnoses. Ordering genetic testing requires matching clinical suspicion with the most appropriate diagnostic approach to maximize diagnostic yield while minimizing cost and time. Multiple congenital anomalies represent the clearest indication for genetic testing. Chromosomal microarray serves as first-line testing, identifying genetic causes in approximately 15 to 20% of infants with multiple unexplained anomalies. Consider karyotype analysis when clinical features suggest balanced chromosomal rearrangements, particularly with ambiguous genitalia or family history of recurrent pregnancy losses. Balanced translocations remain invisible to microarray analysis, making traditional cytogenetics necessary for these scenarios. When specific syndromes enter your differential diagnosis, targeted testing becomes more efficient than broad screening. For infants with conotruncal heart defects, 22q11.2 FISH testing for DiGeorge syndrome provides rapid, cost-effective diagnosis. When clinical features suggest cystic fibrosis, direct CFTR gene analysis offers definitive answers. Family history analysis reveals inheritance patterns that direct testing strategy. Autosomal recessive conditions typically affect siblings but skip generations. Autosomal dominant patterns show vertical transmission through multiple generations. X-linked conditions predominantly affect males with transmission through unaffected carrier mothers. Taking detailed 3-generation family histories reveals these patterns and guides appropriate test selection for maximum diagnostic efficiency. Your role in genetic care extends beyond ordering tests or interpreting results. You often spend more direct time with families than other providers, positioning you uniquely to recognize patterns and provide comprehensive support. Assessment and recognition skills form the foundation. Identifying dysmorphic features requires distinguishing normal variation from clinically significant abnormalities. Focus on facial features, limb proportions, and organ system involvement patterns that suggest genetic syndromes rather than isolated anomalies. Pattern recognition represents the next level. While individual features might seem unrelated, genetic syndromes create recognizable combinations. When you observe cardiac defects combined with immune deficiency and characteristic facial features, consider DiGeorge syndrome and prompt appropriate genetic evaluation. Family history documentation provides crucial diagnostic clues. Gather systematic 3-generation histories that reveal inheritance patterns, consanguinity, or previous unexplained infant deaths. This information guides genetic testing strategies and helps families understand recurrence risks. Coordination responsibilities transform genetic care from isolated consultations into comprehensive management. Orchestrate multidisciplinary teams to ensure genetic findings translate into appropriate subspecialty care and therapeutic interventions. You bridge communications between genetic specialists and primary care teams, translating complex genetic information into actionable clinical plans. Family support acknowledges the profound emotional impact of genetic diagnoses. Provide compassionate communication when delivering unexpected diagnoses, balancing honesty with hope while helping families process complex information and make informed decisions. These high-yield genetic concepts transform genetic evaluation from complexity into systematic recognition skills for immediate clinical application. Inheritance pattern risks provide the mathematical foundation for genetic counseling. Autosomal dominant conditions carry 50% risk because only one affected parent needs to pass the abnormal gene. Autosomal recessive conditions create 25% risk for affected children and 50% carrier risk because both parents must contribute abnormal genes. X-linked conditions affect males 50% of the time when mothers are carriers. Pattern recognition classics you must recognize instantly. Down syndrome combines hypotonia with upslanted palpebral fissures and cardiac defects, typically atrioventricular septal defects. Edwards syndrome shows clenched hands, rocker bottom feet, and universally poor prognosis. Turner syndrome presents with webbed neck, cardiac defects, and short stature in females. DiGeorge syndrome combines conotruncal heart defects with hypocalcemia. Prader-Willi syndrome creates the most hypotonic baby you'll encounter, with severe feeding difficulties and cryptorchidism in males. Diagnostic pearls provide specific thresholds. Cystic fibrosis diagnosis requires sweat chloride levels greater than 60 milliequivalents per liter. Hyperammonemia in the first 24 hours with poor feeding suggests urea cycle defects, particularly without metabolic acidosis. The most critical clinical pearl: test all conotruncal heart defects for 22q11.2 deletion, because this occurs in 15% of cases and impacts both surgical planning and immune management. Potter sequence creates immediate respiratory compromise, requiring urgent intervention due to pulmonary hypoplasia from severe oligohydramnios. A neonate presents with upslanted palpebral fissures, hypotonia, a single palmar crease, and a cardiac murmur consistent with an atrioventricular septal defect. What is the most likely diagnosis? Cryptogenic developmental delay, Down syndrome, trisomy 21, Turner syndrome. This question is testing your ability to recognize the classic physical findings and cardiac associations of Down syndrome. Down syndrome is the correct answer because the combination of upslanted palpebral fissures, hypotonia, single palmar crease, and atrioventricular septal defect are hallmark features of trisomy 21. Cryptogenic developmental delay is incorrect because it doesn't explain the specific physical findings and cardiac defect described. Turner syndrome is incorrect because it typically presents with features like webbed neck, lymphedema of hands-feet, and coarctation of the aorta, rather than the features described in this scenario. A neonate with hypocalcemia and tetany is found to have an interrupted aortic arch on echocardiogram. What genetic testing would be most appropriate to order first? Chromosomal microarray FISH for 22q11.2 deletion, karyotype analysis. This question is testing your knowledge of DiGeorge syndrome's clinical presentation and appropriate diagnostic testing. FISH for 22q11.2 deletion is correct because the combination of hypocalcemia from parathyroid gland hypoplasia, an interrupted aortic arch, a conotruncal cardiac defect strongly suggests DiGeorge syndrome, which is caused by a 22q11.2 deletion, best detected by FISH testing. Chromosomal microarray would eventually be appropriate, but is not the most specific first test for this clinical picture. Karyotype analysis is incorrect because the 22q11.2 deletion is too small to be detected by standard karyotyping. A term infant presents with meconium ileus, requiring surgical intervention. Abdominal radiographs show dilated loops of bowel with a ground glass appearance. What is the most appropriate diagnostic test to confirm the suspected diagnosis? Genetic testing for CFTR mutations, meconium analysis for fat content, sweat chloride test. The correct choice is sweat chloride test. This question is testing your knowledge of cystic fibrosis presentation and diagnostic criteria. Sweat chloride test is correct because it remains the gold standard diagnostic test for cystic fibrosis, with levels greater than 60 milliequivalent confirming the diagnosis. Meconium ileus with ground glass appearance, Neuhauser sign on X-ray, is highly suggestive of CF. Genetic testing for CFTR mutations is useful, but not the first-line confirmatory test. Meconium analysis for fat content is incorrect because it's not a standard diagnostic test for cystic fibrosis. A female neonate presents with lymphedema of the hands and feet, a webbed neck, and low-set ears. Echocardiogram reveals coarctation of the aorta. What is the most likely karyotype for this infant? 47XX plus 18, 45X, 46XX, del 22, Q11.2. The correct choice is 45X. This question is testing your ability to recognize the clinical features of Turner syndrome and correlate them with the correct karyotype. 45X is correct because this karyotype represents Turner syndrome, which classically presents with lymphedema of the hands and feet, webbed neck, low-set ears, and coarctation of the aorta. 47XX plus 18 represents trisomy 18, Edwards syndrome, which presents with different features, including clenched hands and rocker bottom feet. 46XX del 22 Q11.2 represents DiGeorge syndrome, which typically presents with hypocalcemia and different types of cardiac defects. Parents who are both carriers for an autosomal recessive disorder are expecting their first child. What is the chance that this child will be affected by the disorder? 25%, 50%, 100%. The correct choice is 25%. This question is testing your understanding of autosomal recessive inheritance patterns and risk calculations. 25% is correct because when both parents are carriers, heterozygous, for an autosomal recessive condition, each child has a 25% chance of receiving the mutated allele from both parents and thus being affected. 50% is incorrect because that represents the risk when one parent has an autosomal dominant condition, or the chance of being a carrier when both parents are carriers for a recessive condition. 100% is incorrect because that would only occur if both parents were affected, homozygous, for the recessive condition.